which kind of ophthalmoscope you have. All right. Usually the ophthalmoscope, if the ophthalmoscope is working or not, this is the preparation. Is it, you need to see whether is it working or not, does he have batteries or not. You by owning and by making on and off, this will give you an idea that this otoscope is working. You observe here, and in the dial there are numbers attached to it. Okay, and you will there are numbers in the green and numbers in the red. So usually there is 0, then in the green +1, +2, +3, on the red -1, -2, -3, -4, -5. So it will give you, it will actually minimize or maximize your vision while you are inside your ophthalmoscope. So first you need to calibrate that. If you are not wearing any glasses, then you may want to maximize it, yani from +3, +4, so it will give magnifying image of the retina or whatever you are seeing. If you have a refractive error problem, you first need to calibrate it in reference to your eye refractive error, and you can by doing this or by putting it inside your eyes inside, and then you will see that while you are increasing or decreasing the number, you will have good vision or blur vision. If your vision is getting better, so your refractive error is actually equal to this number, so it should be equal to that number, so that to get a good vision. So first you need to make sure that your apparatus is fine. You calibrate it according to your refractive error. Here we will see ophthalmoscopic examination, and we will concentrate on diabetic retinopathies and pediatric examination for red reflex. This is the two objectives that we would like to attain in the primary health care while a patient is coming to you. So first, as we discussed, we need to calibrate the instrument according to your refractive error if present. Then if anyone can come, okay. So we assume that what's your name? Ziad. Okay, Ziad. My name is Dr. Kashan, and today I am going to do some ophthalmoscopic examination, which may requires throwing the light into your eyes, and it may cause some discomfort. Is it okay if you allow me? Yes. All right. First, you will take the consent from the patient. After you take the consent, the objective is number one. For instance, the patient here is a diabetic patient. He comes to you for a regular follow-up. He's on oral hypoglycemics. He is recently observing some problems in the eyes, having some decreased visions, and there is no pain. So we want to make sure that whether the patient has diabetic retinopathy or not. This is our objective. Generally speaking, you will start after you take the consent, you will observe for the red reflex. There are two parts. One is examination from the distance, and one is examination from the closer view. So examination from the distance is, you will ask the patient to look on that wall. So you will ask the patient to focus far away. You will observe that there is red reflex or not. So you will put your eyes, and for instance, this is the eye. You will throw the light here, you will see some red reflex in the patient's eyes. Okay. After you see the red reflex, you can ask the patient to look in that direction. So you start off with the patient to focus on the distant object, and then from the arm's length you can ask the patient, I will also hold you your shoulder so that we don't hit each other. All right. And then afterwards you go inside with this. Okay. Once you are inside the eyes, you will see anterior segment. So there are two parts. One is the anterior segment of the eye, which is before retina, and the other is up to the retina. You see the retina. While you are asking the patient to look far away, and then you will go from the patient arm's length, and you would like to see the anterior segment, whether this the lens is good, anterior segment has good depth, or is there any debris, or is there any opacification and all that. This is for the anterior segment, this is not for the retina. Then you are doing inspection from the arm's length, and then when you go inside and ask the patient to look up forward, you are actually going inside to the pupil. Once you go inside the pupil, you will see any of the retinal vessel. You pick that retinal vessel. Once you go inside, obviously while you are going inside for the retina to palpate, it's ideal to give some medressel to the patient so that the pupils dilated, and you will have a better vision. But before that, you also need to ask the patient, are you going to drive your car alone back home or not? If the patient says okay, no problem, because it will cause some blurry vision after your examination is done. So you also need to explain the patient that I would like to use some medressels which will cause a bit of blurry vision. So it is advisable to manage your transportation accordingly. After you inspect the anterior segment, you will start with the back of the eye, and you pick the blood vessel. I first need to show the retina, right? So if you see here, there are retina, yani you focus is over here on the normal retina. You have retinal vessels, right? The retinal vessels, when you go inside, you will see one of the retinal vessel, and then you can follow that retinal vessel. That retinal vessel will guide you to the optic disc. You find the optic disc, then you assess the optic disc whether there is any. So you go inside the eyes, and then you see that there is a retinal vessel which is okay. So there is no leakage. Is there, because we are doing ophthalmoscope in the context of diabetes, so or hypertension. So is there any cotton wool spots? Is there any leakage in that vessel, that particular vessel? You will find one vessel only when you go inside. Follow that vessel outside, and then it will take you to the optic disc. You assess the optic disc. After you assessing the optic disc, what you want to assess? You want to assess the margins. You want to assess if there is cupping or not, if there is any bleeding blood leakage or not. So after you do that, this is the optic disc. Then you can follow from the optic disc. There are retinal vessels going on. So you can follow 1 or 2 or 3, whatever is visible through your ophthalmoscope, and whatever is possible when you start with medressel. So you still ask the patient, you should focus distant. You follow the optic vessel to the optic disc. After the optic disc you reach, you see that okay, there is no leakage into the vessels. You go inside, outwards, backwards, things like that. After you done that, you ask the patient, look now, when he is doing it, look into the light source. When he is looking into the light source, now you are inspecting macula. So this is how you demonstrate your ophthalmoscopic examination, by doing taking the consent, ask the patient to focus distantly, you check that the instrument is functioning, you calibrate the instrument, positive, negative, whatever is good for you as far as your refractive error is concerned. Then you do red reflex. Once you are done with the red reflex, you will come the arm length. The arm length you will inspect for the anterior segment of the eye, lens, the irises, the depth, there is any opacity or not. After you are done with the anterior segment, you go closer inside. You ask the patient to see the distant object. You will find a retinal vessel. After you find a retinal vessel, you follow that retinal vessel, go to the optic disc. You see that there is no optic disc problem, there is no retinal vessels leakage. Then you ask the patient to look into the light source. Once you ask the patient to look into the light source, you will inspect for the macula, and that is done for your examination. And then you ask the patient to thank and to see. Obviously, before going to that in the examination, you need to ask the patient the history taking, your is there a blood vision or not, if there is any pain in the eyes or not, if there is any infection going on or not. Obviously, these are all the other things that you would like to rule out while you are assessing the patient for diabetic retinopathies, because you are not here to do you are not here to manage all the eye related conditions. Thank you, Ziad.
Thank you.
Okay, now when you see here, this is the it will be more clearer when you go and see in your monitors. It is not here, it's here not very much evident, but you see in the normal there is background diabetic retinopathy, then there is non-proliferative diabetic retinopathies, then there is severe non-proliferative diabetic retinopathies, and then there is neovascularizations. As a primary healthcare physician, it is enough for you to detect that this is normal or it has some diabetic retinopathy to begin with. If the what are the things that you may find in the abnormal diabetic retinopathy? What are the things that you may find in the abnormal diabetic retinopathy? Name one or two things. Cotton wool spots, yes. Maybe, yeah? Silver wiring, yes. And neovascularization. So neovascularization is what? When you follow the retinal vessel, you will have some small retinal vessels. With that big retinal vessel, you will find some neovascularizations going on. Neovascularization is something very evident, should be very evident, and you should diagnose that. Maybe you have a cotton wool spot, maybe you have some exudates in the retina. These are all indicative that this patient is having diabetic retinopathy or hypertensive retinopathy, whatever. Once you make your diagnosis on this, you obviously need to you need to ask the patient to control diabetes or hypertension to begin with, because if you refer the patient to the ophthalmologist, even he will also suggest that he needs to do the diabetic retinopathy, he needs to control the diabetes or hypertension. So this is the first step as a family physician, that you should control his conditions. Number second is you are going to refer the patient out and to see the ophthalmologist opinion, whether this patient requires cauterization and whatever. This is the ophthalmologist domain. You don't need to go into it, that for neovascularization you will do this, for non-proliferative or proliferative diabetic retinopathy. You don't need to go into that detail, but you should be able to know this is the normal retina and that's the abnormal retina. So I would also like you to demonstrate this, practice this on your own, on each other's whenever you've got time to see the normal retina. You should have one retinal vessel picked up and follow that up for any neovascularizations. So this is the normal stages, normal, mild to moderate, moderate to severe, and then neovascularizations. You can go and look up that what are these things, but you should be able to grossly pick it up. So that's one thing. For the adult examination of diabetic retinopathy. For the infants, ophthalmoscope is also very important. We discussed about the red reflex. The red reflex for the children's is different from the red reflex in the adults. Does not have much of that significance. It can give you a cataract thing, because if there is any opacity, it will the red reflex is not going to be present. So you can comment on red reflex to see that the patient has cataract or not. Number one. In the infants, you also need to demonstrate red reflex. In infant, if there is an infant in front of you, you should do a red reflex in that infant to put the throw the light through this ophthalmoscope and observe for the red reflex. If there is red reflex not present in an infant, it's a criteria for referral, because this will have congenital cataract, congenital retinoblastoma, that needs to be addressed by an ophthalmologist. So this is the area where you are going to inspect, and you will going to refer the patient in infants. So this is the scope for the red reflex in the infants. So that's about it about ophthalmoscopes. Any question up till now for the ophthalmoscope? Yes.
We find in ophthalmoscopy any diabetic, do you refer to the ophthalmologist?
And diabetic retinopathy, if we find it, yes, we need to take the ophthalmologist opinion, whatever is the case. And whatever is the case, you still need to counsel him about diabetic management, because diabetic management is not his domain. He will also refer this to the endocrinologist or your family physician to consult about this diabetes. So it's a kind of a shared care approach, but you still need to take the opinion from the ophthalmologist to begin with. As a principle, you should also, as a routine checkup of a follow up of a diabetic or a hypertensive patient, you ask the patient, did you go to the ophthalmologist yearly? He should visit an ophthalmologist yearly for if the patient is diabetic or hypertensive, no matter if he has visual problems or not, because our job is to actually detect occult things and manage them then and there, because once the damage is done, whatever the damage is done, by the way, with this neovascularization or cotton wool spots, whatever the damage is done by these things is not going to reversible, is not going to reverse, because retina does not have the power to regenerate. So we need to detect it earlier and refer the patient to the ophthalmologist, and we also ask the patient to we also need to refer the patient yearly to an ophthalmologist to make sure that there is everything going on right, because all of the family physicians, and we are family physicians, we are not an ophthalmologist to have a 100% comment that this patient does not have any retinopathies. So in order to make sure, you must have an ophthalmologist opinion yearly. So if the patient does not have it, even this is an indication, you can say that routine follow up you should take as you do your routine checkups, the cholesterol, the sugars, you also ask the patient to routinely check your ophthalmologist checkup. All right. So that's about ophthalmoscopic examination.